I'm honored to present this particular speaker, Dr. Anna Volerman. Dr. Volerman is an associate professor of medicine and pediatrics at University of Chicago Medicine and a primary care physician for both children and adults. Her scholarly interests focus on improving systems and reducing structural factors that drive inequities in clinical, community, and educational settings. Dr. Volerman joins me on the executive committee of the CAC Board of Directors, where she serves as vice president. So, Dr. Volerman, I'll pass it over to you.
Awesome. Thank you, Matt. Good afternoon, everyone. It's great to be here. As I'm pulling up my slides, I do want to take a moment to share that I do not normally sound like this. I'm recovering from a cough that has created some laryngitis. So I apologize for the sound of my voice and also for the coughing that will inherently happen at some point during this presentation. Stay with me. I promise I will be back on in a minute if I mute and start coughing. So I am excited to be here today to talk about social determinants of health. And I think this is, really foundational to all of health, that, health doesn't traditionally play out in, just what happens within our hospitals and our clinics. But there are many social factors that impact the health and well-being of individuals. And so I'm excited to jump in. So today I just want to take, focus on taking some time to define the social determinants of health and provide a framework for thinking about them, and then talk about how social determinants of health are related to asthma care and outcomes. And finally, I want to briefly touch on some programs that can impact social determinants of health. And there's a lot more that could be said about many of these programs, but just really want to briefly touch on it. Please feel free to put questions in the chat, and we'll make sure that we get to them during our discussion. So to start, social determinants of health, and I'll, before we dive into the specifics, what I want to take a moment to look at this graphic together. And what this shows you, you can see this, person on the left side. And the reality is that the healthcare that I deliver as a primary care doctor, or that is delivered in emergency departments and hospitals, really only makes up about 20% of an individual's health. And the reality is the socioeconomic factors, as well as the physical environment that they live in and their health behaviors, really contribute to the majority of health and well-being of individuals. We'll focus in today on the 80%, right? And largely on the socioeconomic factors, as well as the physical environment, and think about how those are related to accessing health behaviors and healthcare as it relates to asthma. So first, to define social determinants of health. Social determinants are the non-medical factors that influence health outcomes. One definition that's provided by the World Health Organization is that they are the conditions in the environments where people are every day, right? Where they are the conditions that they're born into, that they live in every day, the conditions that our children learn in and that the adults work in, and also the conditions that individuals are in when they play, they worship, and they age. So there are many different frameworks for looking at social determinants of health. This is one from Healthy People 2030 that's commonly used. So I'll share that one today. But again, I want to reiterate, that depending on the organization you look at, the Centers for Disease Control and Prevention, the Kaiser Family Foundation, et cetera, there are other frameworks that you can look at today. And so this framework shows 5 domains. Again, many of these frameworks are similar in terms of, they might have 6 domains or 4 domains, but they're similar in the content and the various parts that play into them. So let's kind of take a look at these one by one. And first, we're going to talk about them overall, and then we'll take the angle of asthma and apply that to them. So in terms of economic stability, in the United States, 1 in 10 people live in poverty, and many people can't afford those things that many of us consider basic, such as healthy foods, healthcare, and housing. The studies show and evidence shows that people with steady employment are less likely to live in poverty and more likely to be healthy. I think at the same time, we need to acknowledge that many people have trouble finding jobs or keeping a job. There are individuals with disabilities, with injuries, with conditions, whether it be chronic conditions like asthma, physical conditions like arthritis, that may be limited in their ability to do work. And the reality is, even for those individuals who do work, many people don't earn enough to afford the things that they need to stay healthy. Minimum wage varies around this country, and that's really, one between the wages and the benefits that come with employment, can be really important factors in terms of economic stability. Employment programs, counseling, and childcare are really important to help people find and keep jobs, and policies that relate to all of those, whether it be housing, healthcare, education, can really help improve the health and well-being of individuals. So jumping into the education piece, the evidence shows that people with higher levels of education are much more likely to be healthier and to live longer. Children from low-income families, children who have disabilities, and children who experience discrimination are more likely to struggle academically, oftentimes as measured by performance in math or in reading. They're also less likely to graduate from college, and less likely to even get to college and at times graduate from high school. Educational disparities have been strongly linked with employment, as well as housing and the neighborhoods in which individuals can live, and even further with health conditions like heart disease, diabetes, and depression. I think also important to acknowledge that there are children who live in places with poorly performing schools and with segregation among schools, and don't necessarily have access to private schools that may create more opportunities in some settings. It's also important to acknowledge that even for individuals who want to go to college, that there's a high cost to that, and while financial aid plays a role, it does not solve it. And I think also to acknowledge that the stress of living in poverty can be significant and can affect brain development and physical development, which can have further implications for health conditions. Jumping over to healthcare access and quality. Many people in the United States don't get the healthcare that they need. The reality is about 1 in 10 people in the US do not have health insurance. And even among those who do, many are underinsured. People who don't have access to health insurance or have limitations in their health insurance are less likely to access a primary care doctor, and they may not be able to afford the recommended health services or medications that they need. There's been progress made in our country in terms of increasing insurance coverage and helping people get important services. But again, these are not complete. I think in addition to that, oftentimes low education levels are associated with lower health literacy. And that influences the ability of individuals to understand their healthcare and carry out the health plans that are recommended. And also important to acknowledge that the quality of care varies, and there's evidence to suggest that individuals who identify with with racial and ethnic minority groups and with low-income populations are less likely to get the high-quality care that is advised. The neighborhoods people live in also play a major role in terms of health. Many people in the United States live in neighborhoods that have high rates of violence, have unsafe air or water conditions, and also have other risks, whether it be related to health and safety. The reality is, at home and at work, individuals can be exposed to harmful conditions that can influence their health, both in terms of putting them at risk for certain health conditions, but also worsening the health conditions that they have. Data also shows that providing opportunities for people to be active in their communities, to walk, to bike, can increase safety and can improve health and well-being. And finally, beyond the specific neighborhoods that individuals live in, the relationships that people have and the interactions they have with their family, with their community, can be really important for health. Many people face challenges and dangers that they can't control, and this can negatively impact their health. So positive relationships that individuals have, supports within their community, whether it be from loved ones or from other individuals such as teachers, bosses, colleagues, etc., can be really important for improving health and well-being. So now that we've kind of done a brief introduction to each of the domains within the social determinants of health, what I want to do is really look at each of them through the lens of asthma. And before we dive into that, I want to give a little bit of background about asthma prevalence and morbidity. So asthma in the United States affects 25 million people. About 6 million of those are children, 6 to 7 million, depending on the year, and the rest are adults. Although, as you can see, as you look at this graph here, not all groups are affected equally. So the orange line represents all ages, the darker blue line represents the adults, and the light blue line represents children. And you can see here that asthma prevalence is greater among Black populations, among individuals from Native American groups and Asian Pacific Islander groups, and then also individuals who identify with multiple groups, multiple racial and ethnic groups. Among children, you can see the patterns are similar when you look at these light blue lines. The children who identify as Black and from multiple races are at higher risk for asthma, as well as individuals who identify as Hispanic among children. The reality is these disparities for asthma translate over to healthcare utilization and to other aspects of asthma morbidity. So on the left here, you can see a graph that represents emergency department visits based on race and ethnicity. And on the right, you can see asthma hospitalizations based on race and ethnicity. And both of these are pretty prominent in terms of representing that individuals and populations that identify as Black or as non-white or non-Black race have a higher rate of asthma healthcare utilization. In addition, you can see Hispanic populations have a slightly higher rate of emergency department visits and hospitalizations than non-Hispanic individuals. And the data, when you break that data down further based on subgroups, we see that that's driven by particular subgroups. Further, this morbidity, these rates or these disparities that we see for asthma healthcare utilization and morbidity extend to asthma mortality, as you can appreciate here. So those are national data. Those representations are national data. And people often ask about, what about Chicago? And so here you can see two graphs or two figures representing communities around Chicago. And I will say, while this data is over a decade old at this point, the reality is these disparities haven't changed significantly. So on the left, you can see asthma prevalence among children. The green numbers represent asthma rates. The green represents asthma prevalence that is similar to national rates, while the yellow, orange, and red represent progressively higher prevalence of asthma in communities. And you can see that asthma disparities are disproportionately affect the south side and the west side of the city. Similarly, you can see on the right side, this is again a graph for youth or a figure for youth in Chicago. And you can see certain communities represented in the darker blue and in the pink have higher rates of asthma-related emergency department visits per 10,000 individuals. So adjusting for size of those communities. So let's take and apply the lens of social determinants of health as it relates to asthma. So in terms of economic stability, low income has been repeatedly linked to increased asthma prevalence. There's strong evidence that the gaps that exist in terms of income and wealth between populations are strongly connected to asthma rates. You can see here a table that on the left side shows poverty levels, starting with below 100% of the poverty threshold, or really the the lowest income, versus moving all the way up to greater than 450% of the poverty threshold, or those with the higher income. When we look across to see the number of individuals with current asthma and the percentage of individuals with current asthma, you can appreciate, and this is for both adults and children, you can appreciate that asthma prevalence is highest among those who come from the lowest income, who have the lowest income, and the asthma rates decrease progressively as you move to the groups who have higher income, really reflecting a dose response relationship between poverty level and asthma prevalence. The reality is economic instability and low income has been further linked to higher asthma exacerbations, hospitalizations, and even worsening outcomes, including intensive care unit visits. So in one study that looked at adults, they showed that adults who have a household income of less than $50,000 per year had a 1.6 higher rate of asthma treatment failure and a 2 times higher rate of asthma exacerbations, as opposed to those who whose household income was greater than $50,000 per year. Also, studies with children show similar findings. So children who live in extreme poverty, where the household income is less than $10,000, have 125% higher odds of having been admitted to the ICU, right? So being the most severely ill. I think also important to note, right, income is one metric of economic stability. Home ownership is another metric of economic stability that's commonly examined or commonly looked at. And home ownership, so owning a home, was associated with the decreased odds of emergency department visits among children with asthma. Showing that really, if you have the economic stability to purchase a home, and then you are less likely to end up in the emergency department visit. And the reality is that economic stability and low income influences other factors, right? It influences not just can you purchase a home, but also the location of the home, the exposure to pests and pollutions that might be related to that home or to that community, as well as also access to food and healthcare, which are all risk factors for asthma and asthma morbidity. Moving on to look at the intersection between education and asthma. So, as I mentioned earlier, lower educational attainment is related to lower health literacy. And the studies about low health literacy and asthma there are multiple. And in fact, studies show that individuals who have lower health literacy have a decreased understanding of their asthma, perceive a greater need for using their asthma medications, are less likely to be able to follow an asthma action plan. Further, individuals who have limited health literacy have a lower likelihood of being treated by a specialist for severe asthma. They have worse asthma control, they miss more school days, and they have increased emergency department visits and hospitalizations for their asthma. And so really this piece about health literacy, while we don't automatically link education and health systems, the skills one is able to attain in the process of schooling are important for understanding different aspects of health and are thus tied to asthma outcomes related to healthcare access, medication use, and healthcare utilization. So I think also important to note that lower educational achievement is associated with employment opportunity. and employment opportunities tied to employment benefits, right? And our health insurance system, our health system is currently largely or deeply reliant on health insurance through an employer that has improved over the past 10 years, over the past decade, but is still heavily reliant on employment. And so really important to think about, you know, the educational achievement and how that ties into, for both a child and an adult, how that ties into their ability to, you know, have paid sick days, have health insurance, and all of the other aspects that come with employment. So moving on to healthcare access. When we think about social determinants of health, and specifically healthcare access as relates to asthma, the studies show that Black and Latinx families are less likely to, are less likely to have insurance and more likely to live in areas where there are shortages of primary care physicians. Primary care physicians deliver the large majority of asthma care. And as such, for families who don't have insurance and who don't have access or don't have as much access to a primary care physician, that translates into limited access to asthma care. Further, there's a few studies that have looked at children who have the same health insurance and in fact show that Black and Latinx children are less likely to see a specialist for their asthma than white children, even after accounting for severity of the asthma. And so really showing, you know, differences in the quality of care that occurs. Further, if we look at individuals with even more severe asthma who need a biologic for their asthma treatment, patients who have public insurance are less likely to be prescribed a biologic. And further, if you even look at the population of patients who are on public insurance, populations who identify with racial and ethnic minorities are also less likely to be prescribed a biologic for their severe asthma. Moving on to neighborhood and built environment and the intersection of that with asthma. Poor housing quality has been associated with asthma risk and asthma morbidity. When we think about poor housing quality and inability to repair the aspects of the home that need repair, the reality is that translates to a greater exposures to many of the things that are known to be triggers or irritants for asthma. And so greater exposure to pests such as mice and cockroaches and rats, greater exposure to mold, and as well as a greater exposure to indoor air pollution. So thinking about heating systems, stoves, and so on. Outside of the home, the immediate home environment, outdoor air pollution exposure is also greater among individuals who are Black, who live in poverty, and who have lower education. And that is also associated with greater asthma incidence, worse asthma morbidity, and also a greater decline in lung function among those who have asthma. Finally, when we think about the social and the community context, it's important to recognize that these are big drivers, can have large effects on stress. And the reality is that individuals who live in poverty and individuals who identify as racial and ethnic minorities have high levels of stress from many sources, including from economic instability, from lower education, from fewer assets, to barriers to unemployment, food insecurity, exposure to violence, incarceration, and so on. There is data that shows that long-term stress may directly affect asthma by acting on the hypothalamic pituitary adrenal cortical pathways. So those are the things that connect our brain and our adrenal glands. And these are really important areas that drive hormone production, and cortisol use. And there's evidence to show that those impacts have a direct effect on asthma symptoms, and also a decreased responsiveness to asthma medications. So even if that individual has healthcare access, can pay for their healthcare, can pay for their medications, can get those medications, which we already know that there are many barriers to, because of the high levels of stress that they experience, they may be less responsive to those medications. There's also data that shows that early life exposure to environmental stressors, as well as maternal diagnoses of depression or anxiety, are associated with asthma diagnosis down the road. And then high stress in children and adults who have asthma is associated with worse outcomes, including greater exacerbations, worse asthma control, decreased quality of life, decreased lung function, and greater healthcare utilization. So, give me 1 second. Okay, so there are significant social risk factors that exist, and that disproportionately affect certain populations due to, very much structural and societal level causes. And these have significant effects on individuals with asthma, leading to higher chance of having asthma, but also worse outcomes as it relates to their asthma on multiple different aspects of asthma care and outcomes. So then the question becomes, what can we do? And the reality is, I will show this figure from the de Beaumont Foundation that was made a few years ago. And we can see that, the most often in the healthcare system, we act down here. We act at the downstream aspects, right? We can do medical interventions. I can prescribe inhalers. I can, we can deliver, we can give prednisone. We can give biologics. We can do all of these things from a clinical perspective. But the reality is that it's really important to impact those social determinants, because we know that those factors will, will impact the access to healthcare, to these medical interventions and the outcomes. So midstream, when we look upstream, first we can kind of think about midstream and think about acting at the individual level and affecting, addressing individuals' social needs. And then the reality is that that's not enough, that can help individuals, but that's not going to stop these social risk factors from arising. And so it's really important that we also look upstream at the community level and think about the laws, the policies, the regulations, the financing that creates those conditions that allows individuals to be healthy and to have good well-being overall. So screening for social determinants of health, I think, is foundational. And these 3 tools are 3 examples of tools that can be used and that have been used in various clinics and various studies and in various programs. One is the We Care survey here, which is just a series of 6 questions. You can see this was started at Boston Medical Center. This was given, you put a patient sticker on it and you give this to the family to fill out, or you walk through them with those questions. On the right side, there is a tool called Prepare, which has 13 questions, and that get at slightly different factors, but a lot of overlap, a lot of looking at housing, understanding education levels, understanding work situations, health insurance, housing, etc. What I appreciate about both of these tools is that people have the choice not to answer any of these questions, right? Recognizing that oftentimes talking about social determinants of health and screening for them can be stigmatizing for some individuals, and some individuals may be ready to ask for help and others may not. And so creating an opportunity for individuals to say, no, thanks, this is not a question I feel comfortable talking about. There's also a third tool, and I encourage all of you to take a look at it, that was developed by the Centers for Medicare and Medicaid Services through their Accountable Health Communities program, that includes a health-related social needs screening tool. The reality is there's not one perfect tool to use. It's important to tailor the questions that are asked based on the social needs that and the risk factors that we know individuals have in our environment, in whatever environment that you're in, and are prepared to discuss. In terms of addressing social determinants of health, I want to be clear that this really involves a team, and it's not just a team sitting in a clinic or in a hospital or in an emergency department, but it involves a team across clinical and community settings. And social workers, case managers, patient navigators can be part of that team. I've been fortunate to do a lot of work with community health workers. I've really seen their impact in assessing social determinants of health and helping individuals navigate complicated health systems and social systems, and help connect individuals to resources that they need that relate to a variety of the social determinants that we discussed. In addition to team-based care models, there's also opportunities for direct support from community-based organizations that can be really important in addressing social determinants of health. Now, again, I want to acknowledge that many of those things impact or act at an individual level. And so it's really important that we also act at that larger level, right? And one example of policies is really thinking about the payment models. And what are the payment models? Are they paying for are they incentivizing each emergency department visit and each visit, or are they incentivizing the health of an individual and the well-being of an individual? I do also want to acknowledge that the education we provide to clinicians and to teams is critical. The recognition around social determinants of health has happened over the past couple of decades. And so some of the clinicians and who are practicing today, and the healthcare professionals who are practicing today, didn't learn about social determinants of health. And even though they see it every day, they may not be empowered to act. And it's critical that we include that education in continuing education models, but that we also include that education in our training models, so that clinicians and healthcare professionals who are joining the workforce are prepared to understand social determinants of health, to understand how to ask about them, and to understand what they can do, both at the individual patient level with their team, and also at an advocacy level to address social determinants of health. I do want to bring up this visual. This is from the CDC, who's done a lot of work recently in terms of thinking about how they can affect the social and the structural conditions that impact social factors. And it's important to acknowledge that it is not just one person or one clinic or one team, but that it is critical to have data, to be asking about the social factors, to understand the needs that individuals have in communities, and to be monitoring those. It's important to look at the policies and the laws that exist, and advocate for improvements that we know don't happen overnight, but really are critical. It's important to build infrastructure and capacity for influence of social determinants of health. Oftentimes, individuals or individual clinics are tasked with finding resources and how do we step beyond everybody recreating those same pathways or those same resources? How do we engage the community in terms of thinking about influencing social determinants of health, so that it is that they are part of creating the solutions, and that we also think about collaboration across the silos that we often exist within the healthcare world and also outside of the healthcare world, and how do we partner together to do this work, and as we're doing it, to continue to build evidence and evaluate. So in conclusion, social determinants of health affects everyone. They affect everybody that's sitting here on this webinar right now, and they affect the individuals that we care for. They affect our neighbors, our friends, our colleagues, our patients. It's important to be to have a strong understanding of what they are, but also to be asking about them for our patients. As it relates to asthma, disparities are alive and well, unfortunately, both in terms of asthma prevalence and asthma morbidity, and are oftentimes driven by not just one social determinant, by many of these social factors. And it's important that we all take action, both at an individual level and a systems level, to impact social determinants of health so that we can work to create change, both in terms of asthma disparities, but also for for our communities. So I will stop here and stop the share screen and create space for questions from the group.
All right. Thank you, Dr. Volerman. And thank you so much for your presentation, especially since you're feeling sick right now. I do have a couple questions. I'll encourage everyone else to add questions into the chat feature as well, if you have them. But I'll start with a question from Mark Rubin. Interesting that CMS does not include asthma COPD in the Medicare STAR program, except for COPD readmissions. The pharmacy corporate chains, due to non-compensation for providing this education, turn a blind side. How do we get CMS to reflect on this?
A really great question. Sorry. So I think a few different things. I think one, I think this program is probably one of many examples where we think about quality of care and service that's maybe not measured or measured incompletely or measured in a way that doesn't bring attention to asthma. I think I would approach this as I would approach most advocacy efforts, taking a look to see, trying to learn more about the program, bringing attention to the issue, whether it be with research studies, whether it be with, perspective pieces, whether it be with letters directly to CMS, with, strategic partners that we know that have previously influenced them. I think CMS does a lot of the work. I don't want to say a lot of the work, but does a lot of great work in terms of informing what private insurers do and informing what other insurers do. And so I think it is important to, call attention to this issue. I think this piece about education and non-compensation for it, I think that's really an important piece. And I think that's where, thinking about, that education piece isn't in our current healthcare models and our traditional healthcare models, outside of our value-based healthcare models. Education is not reimbursed. It is not, but the reality is we know that education is really foundational for individuals to understand their health condition, whether it be asthma or something else. And so, I think there's work happening and towards moving towards reimbursement for team-based care and other non-physician care members, whether it be asthma educators, community health workers, nurses, for providing education. And I think more efforts, to advocate for those efforts would be important.
Yeah, thank you. And it's good to reflect on this too. And I appreciate, Mark, the lens of your question, which is specifically targeted towards CMS because of the sort of like outsized role that they play in setting policy for not only at the state level, but then for private insurers that have to compete with them. So, it's it is a really tricky question, and I think it would be a good one to be taken up by CAC. And Mark, I would recommend that you email the info address so that we can get that back to one of the CAC committees to specifically talk about a policy implication for that. So thank you for bringing that up. And I wanted to ask too, Anna, about the role that stress plays in asthma, and specifically, like many people will describe like panic attacks feeling very similar to asthma attacks, and that there's a relationship where the more stressed you get and the more sort of like chronic stress that you feel, the more likely it is that you'll have asthma exacerbations as well. And I just wondered if you had any insight on sort of like where the research is with that, and if there's ways that we can like talk with patients about different ways to recognize the difference between panic attacks and asthma exacerbations, and also just sort of recognize the role that stress plays in asthma management.
Yeah, it's a really important question, and I think this is an area that's gotten more attention as there's been more attention given to mental health in our country. I do think um, asthma and panic attacks can be really challenging, right? Because as someone, if you're not the one experiencing it, you are the only person that knows how it feels. Um, and I think sometimes, having people take note of their symptoms when they have asthma and take note of the symptoms when they panic can be really, important. I think oftentimes that shortness of breath can be prominent. Typically a panic attack isn't going to lead to wheezing. It's not going to lead to a cough, but it can lead to shortness of breath, which might create might create some chest tightness, right? And I think helping people be aware of the fact that these things do occur. They both occur, and you can be actually having the same thing, both of them simultaneously, right? Having not being able to breathe can incite further panic. If you don't have that lived experience of like not being able to catch your breath or not being able to stop your coughing, that can really incite, that acute panic sensation or that acute panic feeling. I think giving people strategies of what they can do to address their panic, right? What can they do? And whether it be counting, whether it be taking deep breaths, whether it be squeezing a squeezy ball, etc., right? And so that they've got these strategies that they know, hey, I'm feeling something right now. It might be this, it might be this. Let me listen to my body. Let me make sure I have my asthma pump near me or my asthma inhaler near me, and I'm ready to take it if I need it. Let me try these strategies that I know work for me when I feel panicked. And let me take note. Have I been exposed to any triggers or any irritants? Might there be something that's bringing about my asthma right now, right? And kind of simultaneously work through those. Now, again, that's something that takes a lot of coaching and a lot to get to. And I think getting at the high stress piece, I think the data is pretty clear that high stress does worsen asthma outcomes. I think importantly as a clinician, just starting by having that conversation, right? Acknowledging, in the office or when you're interacting with a patient outside of the office on the phone, even as a community health worker, acknowledging, hey, there's a lot going on in the world right now. Your asthma's been, really solid, or it's been acting up. That can be really stressful. Are you feeling stressed? How has your stress level been? How have you been sleeping? How has your mood been? And even doing, the screenings for depression, anxiety, etc. I think having those conversations is the first step. To bringing attention to it for people, because that asthma the cure of asthma is not just the asthma medications or avoid your triggers. It is also managing those comorbidities, whether they be mental health related, obesity related, allergy related, whatever it is.
Yeah, thank you. And I also wanted to ask about one of the last slide that you showed was some tools to capture social determinants of health, and that got me thinking about, like how fragmentary health records are right now, and how difficult it is to sort of move information, especially for people who are moving physically a lot if they don't necessarily have like stable housing. So how are social determinants of health captured in an EHR, or have you seen, EHRs or clinicians who do that well? Um, and then, like what sort of mechanisms are available to try to make sure um, that this information is readily available for someone who might be accessing care at different sites?
Great question. I think you got me on a soapbox, Matt, because I have strong feelings about electronic medical records and their benefits and their challenges. Um, I will say, I think electronic medical records have a lot of potential. I know we use Epic in my primary care clinic, but there are several out there. And the reality is many of them do have um, tools in there or have the ability to add tools in there that ask social determinants of health questions. So for example, in our Epic system, a couple years ago, they activated the social determinants of health modules, and they are there and I can hover over them and see them if somebody else has answered them. And they are specific questions that have been designed and developed. And the reality is, I think, prior to and for those systems that don't have those modules, but also before those modules existed, I think the reality is much of social determinants of health get captured in our notes. Right, they're words, but they're not systematically captured in the same way we might systematically capture somebody's kidney function based on their blood work, right? It's not something we can map over time easily. It's stories, it's words that are captured, and that's harder to without clicking through each note and seeing, hey, what does each note say? It's harder to follow over time. I will tell you, even for those systems that do have, the pre-existing questions and so on, the reality is with all the other things that clinicians often have to cover, you're probably not going to get to all of those questions all in one time. And so it's important to say, hey, I'm going to ask about this piece today, right? And today we're going to talk about the housing situation. And we might, and next time we might talk about a different piece. And so I think just important to recognize, like, it doesn't have to be all or nothing. It can be asking about a few key topics, right? It might be one time you talk about substance use, another time you talk about housing, another time you talk about this. So just recognizing those time limited aspects. I think in terms of sharing across systems, I think social determinants of health and that information is rarely shared across systems in the same way. We've started to see some electronic medical records be linked for, you can see if someone's been hospitalized or if someone got blood work done. I think we see it, I think that again, because they're described in notes, but they're harder to systematically capture in a way that can be shared across electronic medical records.
Yeah, thank you. And I mean, not to not to just keep harping on this subject, but I'm legitimately curious as, someone who looks at EHRs quite a bit. Like I know that CMS had floated the idea of ICD-10 codes for social determinants that could potentially help to communicate information from a clinician back to an insurance company, or potentially to allow that information to um, be more easily transmitted across multiple practices if someone was using, an FQHC that had multiple locations or something like that. Um, I'm not very familiar with a widespread effort by policymakers or by HFS or anything to get people to adopt those social determinant codes. Um, have you heard of any movement on that? Just like a more concerted, like educational or policy push to get primary care providers and other clinicians to um, interface with the ICD-10 codes?
Yeah, it's a great question. My understanding is they are being adopted for next year, but I um and my understanding is like they have been added, and they are being, they're active and I think, um I will say I think the reality is like for many clinicians, and I don't want to speak for all clinicians, but I think for many clinicians, like we didn't go into medicine to do the billing part. So, right. So whether like, um, it doesn't really matter to me if I, you know, bill for somebody's, if I put in an ICD-10 code that says that somebody has low health literacy or is unemployed, because what impact is that actually having for my patient? Right. I think, and I don't know, but I don't think right now that's tied to any sort of reimbursement. Right. And so, um, if, for example, in one day in an ideal future that I imagine, right, when we are reimbursing for example, for patient navigators or community health workers, then I could envision that those, ICD-10Z codes are being used, to show, what are the social determinants that they're working on, if they're impacting. But for me, whether or not I add, the fact that somebody has problems related to employment or unemployment doesn't change the situation for my patient. And it's an extra step for me to do without actually having any benefit for my patient. And so I think CMS is going to have to give some consideration, and hopefully it will be tied back to financial, benefits, at least in the current healthcare model that we exist in.
Mhm. Um, if I could also ask you about you in one of the slides you mentioned that like advanced therapies like biologics are often not as available in disinvested areas or to people who are at a low income level. And I was wondering if you could talk a little bit about the barriers to people receiving access to biologics. And then I also wanted to ask if that's also true for allergy shots and other sort of like advanced therapies that are an ongoing injection or just sort of like persistent follow-up at a doctor's office.
Yeah, it's a great question. I think first to say, like, no primary care doctor I shouldn't say no. Typically, biologics and allergy shots are given by a subspecialist, right? They're not given in a primary care office unless somebody has unique training in those areas. And so, just simply the fact alone that, individuals or populations that are from low income households who are Black or Hispanic or Latinx, are less likely to see a specialist also means that they're less likely to have allergy shots or less likely to receive biologics. So I think that's like the first really foundational piece we need to realize is like they can't even be offered it if they don't make it to that office or to that appointment, or to see that clinician, right? And then I just brought up other barriers, like transportation, like taking time off work, all of these other pieces. Um, I do think that those factors really play, a big role, in access to biologics. Um, I think also, I think just the reality of like historically what's happened in our healthcare system and how various populations were, treated. I think, there's questions about, biologics or allergy shots or anything that involves injections. There's a huge distrust of the healthcare system, and then on top of it, things that, that you don't hear other, family members or friends or others receiving, makes you wonder. I think also you need to be able to, consider the cost aspect of it. And oftentimes there's multiple hoops to jump through in terms of um, prior authorizations, cost, etc. That again is not easy to navigate. And so I think for all those reasons, both biologics for asthma, but also allergy shots can be access to those can be limited.
Yeah. Well, thank you, Dr. Volerman, so much for your presentation and for your patience answering these questions.
Thank you for
And
having me. And if folks have any other questions, feel free to put them in the chat. I'll watch as we move forward. Thank you so much for having me and for bearing with my beautiful voice.